Welcome to This Explainer. Today, we are putting together a visually structured survival guide for high-yield pediatric respiratory conditions. If you're looking to really master this complex system without getting bogged down, you are absolutely in the right place. We're going to take a timeline approach, basically looking at how different respiratory issues pop up as a child grows. It's a great way to transform what feels like a massive, overwhelming list of diseases into a really logical, easy-to-remember narrative. Here is our game plan. We're starting right from the newborn nursery with congenital airway anomalies, then moving through cystic fibrosis, childhood infections like croup and bronchiolitis, asthma, foreign body aspiration, and wrapping it all up with sleep-disordered breathing. Let's get right into it. All right, Section 1, Congenital Airway Anomalies. Okay, picture this. Why would a newborn baby turn blue while feeding, but then instantly turn pink the second they start crying? This classic clinical mystery is honestly the ultimate aha moment once you truly understand neonatal anatomy. It sounds completely paradoxical, right? Because crying usually means a baby is in distress, but here, the crying is actually the cure. Well, the answer to that mystery is choanal atresia. Basically, during fetal development, the posterior nasal passage just fails to canalize or open up, leaving a physical blockage. Now, because babies are obligate nasal breathers, their airway gets fully blocked while they're trying to feed. But once they become hypoxic and start to cry, that crying forces them to breathe through their mouths. This temporarily bypasses the blocked nose, and boom, they turn pink again. What's really wild about this is how the severity of the blockage completely shifts the timeline of when you actually figure it out. Unilateral choanal atresia is by far the most common form, but because the baby can still breathe fine through the other nostril, it often goes completely unnoticed until childhood. It just presents as chronic nasal discharge. Bilateral atresia, on the other hand, that is a neonatal emergency. You're going to spot that right after birth because of the noisy breathing and that cyclic cyanosis we just talked about. Moving right along, Section 2, Cystic Fibrosis. Let's map out the systemic domino effect of cystic fibrosis. It all starts with a single autosomal recessive mutation in the CFTR gene, which completely disrupts chloride transport. And since chloride can't move properly, water doesn't follow it. The end result is this incredibly thick, dehydrated mucus. In a newborn, that sticky mucus can cause meconium ileus, which is a bowel obstruction, and in the lungs, it becomes this perfect trap for recurrent sinopulmonary infections. You're specifically looking out for Staphylococcus aureus in younger kids, and then Pseudomonas as they get a bit older. So how do we lock in the diagnosis? You're looking for that classic, highly testable clinical clue, abnormally salty sweat. The gold standard here is the sweat chloride test. If you see a concentration greater than 60 milliequivalents per liter, that's diagnostic. But to pinpoint the exact mutation, which is absolutely vital these days for targeted gene therapies, you've got to follow up with genetic testing for the most accurate confirmation. Okay, on to Section 3, Croup and Bronchiolitis. Check this out. This is Croup, or medically laryngotracheitis. It's usually caused by the parainfluenza virus. The inflammation here specifically targets the upper airway, so the larynx and trachea. On the flip side, we have bronchiolitis. Now, this is a lower respiratory tract infection. It's heavily driven by the respiratory syncytial virus, or RSV, and it overwhelmingly targets kids under 2 years old. Because the infection is happening down in the tiny bronchioles deep inside the lungs, you aren't going to hear that upper airway stridor. Instead, you're going to hear expiratory wheezing and crackles. And the cornerstone of treatment for this? It's really just supportive care, hydration and suctioning. Let's put these two head-to-head to build out our differential diagnosis. Pitting them directly against each other is honestly a game changer for retention. Croup is upper airway, gives you inspiratory stridor and responds beautifully to corticosteroids and nebulized epinephrine to shrink down that swollen tissue. Bronchiolitis is lower airway, gives you expiratory wheezing, and relies almost entirely on supportive care. Upper versus lower, stridor versus wheeze. Keep those straight and you are golden. All right, Section 4. Asthma and reactive airways. You probably already know that asthma is the most common pediatric disease out there. It's driven by chronic inflammation that leads to recurrent episodes of wheezing, chest tightness, and dyspnea. And interestingly, these are often triggered by exercise or allergens with zero signs of an actual infection. Because asthma is an obstructive disease, a chest X-ray is going to show hyperinflation. But the real diagnostic key, proving that this airway obstruction is actually reversible when you administer a beta-2 agonist like albuterol. But here is the absolutely crucial takeaway. You have got to recognize when an asthma attack is turning deadly. It's a real trap to assume that worse asthma just means louder wheezing. In reality, an absence of wheezing, what we call a silent chest, is a massive red flag. It indicates dangerously poor air exchange. If your patient is fatigued, has altered mental status, and you literally cannot hear air moving, they're in respiratory failure. They need immediate, aggressive intervention right then and there. Next up, Section 5, Foreign Body Aspiration. Imagine a totally healthy toddler, say 1 to 3 years old, who suddenly develops an asymmetric wheeze or a sudden onset cough right after eating peanuts or playing with tiny toys. When that happens, you have to suspect a foreign body aspiration. The object usually ends up lodging in one of the main bronchi, very often on the right side. So you're going to hear a focal monophonic wheeze and diminished breath sounds strictly on that affected side. Amazingly, the chest x-ray will often show a hyperinflated lung on the affected side because the object is basically acting like a one-way valve, trapping air during expiration. When you suspect this, you have to follow an exact, rapid-fire protocol. Step 1 is always basic life support. You attempt to clear a severe choking episode with back blows or the Heimlich maneuver. Now, if they are stable but still symptomatic, you move to Step 2, get a chest x-ray and look for hyperinflation and mediastinal shift. And Step 3, if the object is still in there, you don't wait around. You rush them in for an immediate rigid bronchoscopy to extract it. And finally, Section 6, Sleep-Disordered Breathing. This slide tackles a really massive misconception. Pediatric obstructive sleep apnea, which is mostly caused by enlarged tonsils and adenoids, is not just about loud snoring at night. The poor sleep quality it causes leads to severe daytime behavioral problems. We're talking inattention, hyperactivity, and irritability. It is incredibly common for these kids to be misdiagnosed with ADHD, when in reality, they just need their tonsils taken out so they can breathe and finally get some sleep. Wow, we have covered a ton of ground today, right? From the cyanotic feeding newborn all the way to the snoring, hyperactive school child. Whether it's noisy breathing or silent airways, the clinical clues are literally always right in front of you as long as you know how to structure your thinking. So the real question is, will you know what to listen for when it matters most? Thank you so much for joining me for this explainer. Keep structured, keep learning, and always trust the clinical clues. Catch you next time.